All right, nurses, let's talk about the pathophysiology of various renal urinary tract conditions in children. First, we need to get familiar with how the kidney develops. So, a process called embryonic folding occurs during the 4th week of development. This marks the beginning of the urinary tract with the formation of a longitudinal mass known as the urogenital ridge. That ridge divides into parts depending on the system it forms. The nephrogenic cord, which you see here in the kind of blue-green color here, that will form the urinary tract. And then a nearby ridge called the gonadal ridge will form the reproductive system. The gonadal ridge is not shown here, but the gonadal ridge would be medial to the nephrogenic ridge. So beginning at the front rostrally and then progressing caudally towards the back, you'll have 3 different kidneys that form over a few weeks within that nephrogenic cord. They are the pronephros, the mesonephros, and the metanephros. The pronephros, which you see here, is also known as the Wolffian duct. It begins development in the 4th week. It will not form functioning kidneys in humans. It forms functioning kidneys in other species, but not in humans. Pronephric ducts form in the cervical region of the nephrogenic cord before extending and fusing all the way down here with the cloaca. Adjacent to the pronephric ducts, the intermediate mesoderm will condense and form these nephron units. These are non-functioning. And these are known as pronephroi, and they will regress by day 25. The mesonephric duct, also known as the Wolffian duct, this will begin development in the next most caudal region of the nephrogenic cord, and the adjacent intermediate mesoderm condenses to form mesonephroi that you see here in the red. Although about 40 pairs of the mesonephroi form, only those located between L1 to L3 continue to differentiate to form functional excretory units. About 20 nephrons will form that are capable of excreting small amounts of fluid into the amnion between the 6th and 10th week of development. Similar to the pronephroi, the mesonephros and mesonephric duct will later degenerate in females, but in males, this ductal system will persist, and it develops into the epididymis, the vas deferens, the seminal vesicles, and the ejaculatory duct. The 3rd and final kidney, which you see down here, the metanephric kidney, begins development during the 5th week. It will continue to differentiate into the permanent kidneys. The mesonephric duct extends to fuse with the cloaca, and that induces the sacral intermediate mesoderm to form an aggregate known as the metanephric blastema. At the beginning of week 5, the metanephric blastema secretes a protein known as glial cell-derived neurotrophic factor. Glial cell-derived neurotrophic factor, which is mercifully abbreviated GDNF. This induces an outgrowth. The GDNF induces an outgrowth in the mesonephric duct known as the ureteric bud. And the ureteric bud, as you can see, grows into the metanephric blastema. The tissue of the ureteric bud contains a receptor for GDNF, and it is the RET proto-oncogene product, the RET receptor. And there's a co-receptor as well called the GDNF family receptor alpha 1, or the GFR alpha 1. Both of these are strongly expressed in the tissue that will become the ureteric duct. During the 6th week of development, that ureteric bud forms a branching cascade, which will subsequently create collecting tubules and the basic renal architecture. That's shown here on the next slide. The first bifurcation occurs about the 6th week, and that will form the renal pelvis, as well as the cranial and caudal lobes of the kidney. The next 4 bifurcations coalesce to form the major calyces. The following 4 bifurcations coalesce in the 7th week to form the minor calyces. Branching is induced by GDNF acting on the REAT-expressing cells from the tips of the ureteric bud. Each individual branch requires a blastema cap from which GDNF gets secreted. This cascade continues until week 32, producing some 1 million to 3 million collecting tubules. Functional neurons begin to form, as you can see here in panel B, when the tip of each collecting tubule induces the blastema caps to form nephric vesicles. Here's the vesicle up here. These then develop into nephric tubules consisting of an S-shaped Bowman's capsule that you see here, proximal and distal tubules, and then the loop of Henle. The development of the glomerulus occurs over here when podocyte precursors lining the S-shaped body secrete VEGF2, that's vascular endothelial growth factor 2, that attracts endothelial cells to generate a primitive vascular tuft that you can see here. This activity will form the afferent and efferent arterioles of the glomerulus. Contact between the podocyte precursors and the endothelial cells stimulate differentiation of the podocytes, with the glomerular basement membrane forming at the boundary between the two. You can see that happening here. The distal end of the nephric duct and the distal convoluted tubule fuses with the collecting duct to form a uriniferous tubule, and you can see that here. During early development, the kidneys lie close together in the sacral region of the embryo. As the abdomen enlarges, the kidneys are drawn apart and they ascend to their final position in the lumbar region between weeks 6 to 9. The kidneys receive vascular supply from branches of the dorsal aorta, from branches known as renal arteries. During their ascent, the caudal branches degenerate and the kidneys receive their blood from successively higher branches. The development of the bladder begins during week 4, when the urogenital septum divides the cloaca into 2 parts. Posteriorly, you'll have the rectum, and anteriorly, you have the so-called urogenital sinus. The urogenital sinus will grow to form the bladder, with the inferior end forming the urethra. As the mesonephric duct fuses with the cloaca, part of that duct gets incorporated into the posterior wall of the bladder. Although the ureteric bud is an outgrowth from the mesenteric duct, it has a separate opening into the urinary bladder. As the kidneys ascend, the ureters elongate and open into the bladder superiorly. The roots of the mesonephric ducts are carried inferiorly before fusing to form the trigone area of the bladder, and then endodermal cells from the urogenital sinus will replace the endodermal cell epithelium of the trigone region, and that completes development of the bladder. There are lots and lots and lots and lots of signaling events, lots of interesting genes expressed. Mutations in those genes can cause problems with kidney development and so on and so forth. Problems with the kidney can occur if the kidney field fuses at the beginning. You don't have 2 separate kidneys, you just have one. Metanephric blastema. That forms a so-called horseshoe kidney. When that horseshoe kidney rises, the horseshoe kidneys can sometimes get stuck on certain vessels in which case the kidneys will be a little bit lower in the body cavity. Many people with horseshoe kidneys don't have any symptoms at all. So unless this causes symptoms, it is not treated. So hypospadias are an anatomical congenital malformation of the male external genitalia. It's characterized by abnormal development of the urethral fold and the ventral foreskin of the penis that causes abnormal positioning of the urethral opening. In hypospadias, the external urethral meatus, the opening, may present various degrees of malpositioning. It may be found with associated penile curvature. Depending on the location of the defect, patients may have an additional genitourinary malformation. There are good surgical procedures to fix this in kids who are less than 12 months old. It's a single-stage repair that has relatively good outcomes. Epispadias very often occur with so-called exotrophies. Exotrophies are developmental defects whereby the abdominal wall fails to close around the bladder, so the bladder is actually external to the body wall. So if you have epispadias with exotrophy, it's called an exotrophy epispadia complex, or EEC. That comprises a spectrum of increasingly complex congenital anomalies, including epispadias, classic bladder exotrophy, and cloacal exotrophy. Each of these seems to result from the same embryologic defect, and there are variations on these as well. So the main reason these seem to form is failure of mesodermal ingrowth to reinforce the cloacal membrane. The cloacal membrane is a layer of endodermal and ectodermal tissue located at the back of the germinal disc of the lower abdominal wall. During weeks 4 and 5 of gestation and normal development, mesenchymal ingrowth between these layers forms the lower abdominal muscles and the bony pelvis. Continued descent of the urorectal septum results in fusion with the cloacal membrane and a separation of the primitive cloaca into the urogenital sinus and the hindgut, or the rectum. Perforation of the cloacal membrane usually should occur after fusion at about 6 weeks of development. Failure of the mesenchyme to migrate between the ectodermal and endodermal layers of the lower abdominal wall leads to instability of the cloacal membrane, causing the risk of premature rupture. And the timing and degree of premature rupture of this cloacal membrane results in the spectrum of conditions seen in exotrophy epispadia complexes, with cloacal exotrophy being the earliest defect and just isolated epispadias being later defects. So epispadias, isolated epispadias are pretty rare. And in this case, the urethral opening is on the dorsal surface of the penis. In isolated epispadias, you have normal bladder formation, but there's incomplete urethral tubularization distal to the bladder neck. It is much more frequently noted in males, and even in males, it's relatively rare. And again, there are several different surgical techniques for fixing this, with outcomes being pretty good. It is very rare in females. It occurs in females, but it's quite rare. Here's a picture of a hypospadia in a male child. You can see the urethral meatus is not located properly, and also the penis shows hypoformation as well. Other types of various abnormalities include various types of obstructions. So you can have bladder outlet obstructions. So this is a relatively rare birth defect characterized by partial or complete blockage of the urethra. This can be caused by scar tissue, bladder stones, tumors in the rectum, and the decreased flow of urine leads to swelling of the urinary tract, and that can back up to the kidney and cause hydronephrosis. You can also have a so-called UPJ. This is a uretopelvic junction obstruction. So this is a blockage. The uretopelvic junction is located where the pelvis of the kidney meets the ureter. That's the uretopelvic junction. So uretopelvic junction obstruction refers to a blockage in that particular area. The obstruction impedes the flow of urine down to the bladder. That causes urine to back up in the kidney and dilate it. This usually gets detected with ultrasound during pregnancy. And this occurs during fetal development. Most of the time, the blockage is caused when the connection between the ureter and the renal pelvis narrows. UPJ obstruction can also be due to scar tissue. That would be secondary UPJ. It could also be caused by infection, a benign polyp, or even kidney stones. Hypoplastic or dysplastic kidneys refer to problems during renal development. So hypoplastic kidneys, these essentially mean that the kidney just is too small. It's very small. You don't have very many nephrons. You simply did not have very good cell division during development. So the kidneys, they're smaller than normal, reduced nephron number, and this can be unilateral or bilateral. Dysplastic kidneys means that the development of the kidney has gone awry. So the kidney is there, but the development is just not normal. So you can have multicystic dysplastic kidney that results from kidney malformation during fetal development. This usually has a genetic cause. This is due to mutations in three different genes that are known to be essential for kidney development. There's a gene called eyes absent 1, the 6-1 gene, and then PAX2 is another gene that can cause dysplastic kidneys. Again, this can be unilateral or bilateral. Polycystic kidney disease. In this case, you have the nephrons essentially form cysts, vesicles, and those vesicles are not connected to a ductal system, so they may make urine within the cysts. Polycystic kidney disease can develop gradually, and it's due to genetic defects in the polycystin 1 or polycystin 2 genes. Renal agenesis refers to a complete failure of the kidneys to form. If the kidneys do not form, then you have a condition in the fetus that can be very severe. So once the face is made and the baby begins to swallow, the kidneys are now working and the amniotic fluid is recycled through the urinary tract of the fetus. With renal agenesis, the amniotic fluid gets swallowed and it's not recycled. So that causes a condition called oligohydramnios. That's oligohydramnios, oligohydramnios. So because the fetus has to develop in reduced amounts of amniotic fluid, it can cause pulmonary hypoplasia, cranial abnormalities, and clubbed feet. And this set of abnormalities due to oligohydramnios is called the Potter sequence. And it's due to renal agenesis. It can also be due to atresia of the ureter or urethra, causing obstruction of the urinary tract. Renal hypoplasia can cause this too. Uroplacental and ureteroplacental insufficiency from maternal hypertension, that can cause Potter sequences as well. A patient is born with abnormal differentiation of renal tissues. What's the term that describes this condition? Renal agenesis means that there are no kidneys. A hypoplastic kidney means that the kidneys are there, they're just small. The term here that seems to work is the renal dysplasia, since dysplasia refers to abnormal development. There's really no such thing as renal aplasia. So the answer there is B. So glomerulonephritis can occur in a little one. Various types of infections can cause this. The most common type of nephritic syndrome in kids is post-streptococcal glomerulonephritis. This occurs 2 to 4 weeks after a group A streptococcal infection of the pharynx, or 2 to 4 weeks after a skin infection like impetigo. Remember that the immune system and the antibiotics that were given blast the streptococcal cells to smithereens. Antibodies against the cell debris bind to it, and that cell debris antibody complex gets stuck in the podocyte glomerulus boundary. These immune complexes, after they get deposited in the glomerular basement membrane, they will initiate an inflammatory reaction in the glomerulus that involves activation and deposition of complement. The complement C3 protein in particular will get lodged in the glomerular basement membrane. This damages the podocytes. So lab tests will show low levels of C3, complement C3 in the blood. Strep titers and strep serologies will be positive. And the glomeruli on light microscope will be enlarged and hypercellular. On immunofluorescence, there are IgM, IgG, and C3 deposits. And the subepithelial deposits appear as humps. In children, fortunately, this resolves on its own. In adults, it can lead to renal failure. So age greatly affects prognosis. IgA nephropathy, formerly called Berger's disease, occurs if your child makes abnormal IgA molecules that don't have the proper sugars attached to them. The body recognizes those rogue IgA molecules as foreign. It makes antibodies against those IgA molecules. The IgA, IgG complexes get lodged in the mesangium tissue in the Bowman's capsule. The mesangium tissue provides structural support to the glomerular capillaries. You activate the alternative complement pathway, you get the release of pro-inflammatory cytokines, migration of macrophages to the kidney, all of which will contribute to glomerular injury. These antibodies are secreted in response to respiratory and GI tract infections. This condition will occur days after the infection. That's an important difference between this condition and the post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis occurs 2 to 4 weeks after the infection. This one occurs days after the infection. This is also different from Henoch-Schönlein purpura, which is an IgA-mediated vasculitis. And in that case, you also have colicky abdominal pain, bloody stool, arthritis, and then palpable skin lesions, purpuras, on the extensor surfaces of the lower extremities typically. The most common nephrotic syndrome in children is minimal change disease. And minimal change disease, remember, responds very well to corticosteroids. And that is T-cell mediated. Hemolytic uremic condition, we've already gone over that in class. You have infection by Shiga toxin producing Shigella or Escherichia coli. You have an abdominal infection usually, and then that proceeds to, you get thrombosis, thrombocytopenia, and an intravascular hemolytic anemia. So again, this is an immune complex. This is a type 3 immediate hypersensitivity condition, the acute post-streptococcal glomerulonephritis. IgA nephropathy also is a type 3, since it has to do with antibody-antigen complexes. The Henoch-Schönlein purpura, that also involves IgA, whereas the IgA nephropathy just affects the kidney. Henoch-Schönlein purpura, sometimes called IgA vasculitis, also involves arthritis, abdominal pain, and skin lesions. Henoch-Schönlein purpura, by the way, is a small vessel vasculitis. Focal segmental glomerulosclerosis is usually only seen in children if they have one of the conditions that can produce it. This, remember, is seen mainly in individuals of African or Hispanic descent. It's associated again with HIV infection, interferon treatment, or with congenital malformations of the kidney. In this case, there is effacement of the podocyte foot processes that causes sclerosis or hyalinosis of the glomeruli. And immunofluorescence is usually negative, but it can be positive for deposits of C3, C1, or IgM. And this particular condition does not respond all that well to corticosteroids. Remember, the signs of nephrotic syndrome include peripheral and periorbital edema. So the periorbital edema might be your first sign. Hypoalbuminemia, proteinuria, hyperlipidemia, and then the patient is also at risk for thrombosis because they lose antithrombin 3 through the kidney. Hemolytic uremic syndrome, most common cause of acute renal failure in children, and it's usually associated with bacteria, less often with viral agents, usually Shiga toxin producing strains of E. coli or Shigella flexneri. This toxin will damage red cells and endothelial cells. The damaged endothelial cells induce the formation of clots. The clots provide these strings across vessels that shred red blood cells. You have schistocytes upon a blood draw. The endothelial lining of the glomerulus gets damaged. It becomes swollen. It gets filled up with clots. Fortunately, this condition has a pretty good prognosis. Usually, you give patients platelets because there's a thrombocytopenia. Fibrinolytics are usually not needed, but if it's severe, you can give them, and then usually the patient may need antibiotics. But usually, this occurs after the GI infection has cleared. So this is an intravascular hemolytic anemia. And the schistocytes, the damaged red cells, get removed by the spleen. So you get the hemolytic anemia, and you get lots of clots everywhere as well. Again, prognosis is pretty good. You start with a GI illness almost always. So you have the first signs of anemia and places where you have clots in the skin. So you get purpura, bruising, pallor, oliguria, and then later you get fever, vomiting, diarrhea with the characteristic watery blood-stained stools, abdominal pain, mild jaundice, circulatory overload because the kidneys aren't working. In severe cases, you can hook the child up to a hemodialysis machine just to get them past the time when their kidney is not working. Seizures and lethargy usually indicate CNS involvement. If the azotemia gets really bad, then hemodialysis is warranted. Patient is experiencing proteinuria, hyperproteinemia, hyperlipidemia, and edema. Those are classic nephrotic syndrome symptoms. These others, you don't know, you don't have other information to say that they have IgA nephropathy or glomerulonephritis or hemolytic uremic syndrome. So nephrotic syndrome seems like the best guess here. Wilms tumor is a childhood cancer of the kidney. It's due to mutations in a tumor suppressor gene, and it's called WT1, the Wilms tumor gene 1. So usually there'll be a painless, palpable abdominal mass. The child will have loss of appetite, usually abdominal pain as well, and a fever. In about 20% of cases, there's blood in the urine. There'll also be nausea and vomiting. In some cases, there's high blood pressure. Wilms tumor, fortunately, is highly responsive to treatment, and surgical removal usually fixes the problem completely. About 90% of patients are cured of this. So if the tumor is not dealt with, then it can become a nephroblastoma that can become aggressive. A malignant Wilms tumor is called a metanephric blastema. No, it's not, sorry. It contains metanephric blastema, stroma, and epithelial derivatives. Anaplastic Wilms tumors contain poorly developed cells and are much more aggressive. Some of these forms are inherited, others are sporadic. The Wilms tumor gene, by the way, is on the short arm of chromosome 11. Urinary tract infections are pretty common in 7 to 11-year-old gals. E. coli, or members of the genus Proteus, are the most common bacterial pathogens. These are highly motile organisms that ascend the urethra and cause an uncomplicated cystitis. If they go up the ureters, they can cause a pyelonephritis. Kids this age usually get UTIs because they are being trained in proper toilet hygiene, and they may not get it right. So that can cause UTIs. Other times, they just may not, they may re-wear unwashed underwear or something like that. There are lots of different reasons why gals can get these infections. If they get them, they will typically show symptoms, the dysuria, the pain during urination, the burning, the itching, the pelvic pain, and don't give them cranberry juice or something like that. Get them treated, because then they can become pyelonephritis. So vesical ureteral reflux, that again is the result of a defect in the connection between the ureter and the bladder. The ureter connection has a little valve that essentially prevents, so when the bladder gets full, that valve essentially shuts. And so this condition allows urine to flow backward from the bladder into one or both ureters and then into the renal calyces. So because urine normally travels anterograde forward from the kidneys to the bladder via the ureters, that little vesico-ureteral junction that prevents backflow, the valve, is formed because you get an oblique tunneling of the distal ureter through the wall of the bladder. That creates a short length of the ureter that can be compressed as the bladder refills, and that prevents urine from backflowing into the ureters. Most children with this are asymptomatic. Usually on ultrasound, you see dilation of the kidney. The reflux increases the risk of bladder and kidney infections. So if you have a kid with persistent, recurrent infections, they should be tested for this. This can usually be ascertained via ultrasound. In infants, the sign of a urinary tract infection may only include fever and lethargy, with poor appetite and sometimes foul-smelling urine. Older children will have the discomfort or pain with urination and frequent urination. So with babies, it can be hard to spot. Fortunately, ultrasound can diagnose this usually pretty easily. So so-called voiding cystourethrogram, or a VCUJ, diagnoses this usually pretty easily. The goal of treatment usually is to minimize infections. There are different grades of VUR. There are surgical management techniques. There are laparoscopic robot-assisted techniques. These can work. Their track record is not stellar, but they can work. My guess is that the technology is only going to get better. And so you'll have, I think it's called the sting hit procedure is the technique that's usually used to treat the really severe cases of VUR. Enuresis is very simply bedwetting. This is relatively common, and it's just involuntary passage of urine, usually when the kid's asleep. When voluntary bladder control should have been acquired, this will tend to run in families. The nighttime is far more common than the daytime. Secondary enuresis can be the result of either a hernia or a bladder infection or something like that. Primary enuresis occurs if the child has never been continent. Primary enuresis is usually an indication that there is something structurally wrong with the child's urinary tract. So looking essentially at the urinary tract in some detail is quite important. There's a drug called viloxazine that is used in the treatment. It's been used for ADHD. And this is also used for primary enuresis. Lots of reasons for enuresis. And the list is here. Some kids will have so-called giggling incontinence, where they urinate when they laugh. Others have stress incontinence, where they urinate when increased abdominal pressure occurs, such as in coughing. For someone to be diagnosed with enuresis, they have to be at least 5 years old, and they have to have bedwetting that occurs 2 times a week over the last 3 months, and a recurrence of bedwetting after 6 months of no bedwetting. Or, excuse me, a recurrence of bedwetting after 6 months of bedwetting. Children with enuresis have lower functional bladder capacity than healthy children. Their bladders hold less. And voiding and storage problems can also be an issue as well. So can this condition called bladder instability. Management of this incurs both nocturnal and daytime behavioral therapy. There are drugs that can treat this. Treatment of enuresis for kids under 5 years old is not recommended. It's different for adults, but for kids, usually 5-year-old is that issue. Some kids just drink too much before they go to bed, and that can be an issue. And that's all she wrote for this chapter.